Welcome to Community Conversations. I'm your host, Steve Mantis, and my guest today is Jean, Bartkowiak. Did I get it?
Yes.
Oh my gosh, thank you. Just before I start, we're just starting a new season here on Shaw Cable Spotlight, and I want to put out a big word of thanks to the staff and the volunteers here at Shaw. I usually leave it till the end of the show and then we run out of time, but we couldn't do any of this without the great support of the folks here at Shaw. So big thank you so much to that. So coming back to the focus of our show, Jean, so you're the CEO and the president of the Thunder Bay Regional Health Sciences Center and the related Research Institute.
Right.
You got a lot on your shoulders there, partner.
I have many people to support those shoulders, though.
Right on. So tell us a little bit about your own background. Are you from Thunder Bay, or when did you come here?
I'm born and raised Montrealer, but then trained partly in Montreal, but then moved to Toronto. Did my graduate degree in health administration, and then my first job was in New Brunswick in a 500-bed mental health facility. My role there was to start the institutionalizing mentally incapacitated patients.
Moving people into the community
outside,
more.
Yeah, make mental health less of a destination, more transition to community services.
Like we did here in Thunder Bay with our LPH.
Yeah, exactly. And then I was recruited at the Heart and Lung Institute in Quebec City, where I was the chief operating officer. Helped develop heart and lung transplant programs with the surgeons there, which is in part probably why I was recruited here, because this is one program where we intend to invest in the coming years.
In heart and lung transplants?
Not transplants, no, just open heart surgery.
Oh my gosh.
Yeah, we don't have volumes to justify that.
Right.
Then I got my first appointment as a CEO in a 300-bed community hospital in central Quebec. Worked there for 10 years and gradually took on different challenges, such as supervising another hospital and being interim CEO of a regional facility. So I had many different functions. Eventually led the largest regional facility in Quebec. Then moved in Ontario, where I was the CEO of a St. Joe's-like facility, Briere Continuing Care. Did that for a number of years. Then I left the field thinking of early retirement, but that led me to my own demise. I broke my neck in an accident.
Oh my gosh.
And was in rehab for a year. That's when my wife decided that retirement was not fit for me. So
Were you doing risky things or what?
Well, I was bicycling, yes.
Okay.
And I shouldn't have done that, but I was in a hurry not to miss an appointment. So I was recruited to help a very small hospital in the Northeast Lynn, recruit a new CEO and do the CEO job while the board was looking for a new CEO. I did that for a year. Came back to Ottawa, and then I got the call here. The headhunting firm were keen on having me on the interview panel, and one thing led to another. I was the successful candidate, and I've been here a little over 3.5 years now.
So how do you like Thunder Bay? You've been all over the place. You got a lot to compare us to. How do we stand up?
It's a beautiful town, beautiful facility. I've been a surveyor for Accreditation Canada for 15 years, surveyed in Canada and abroad, and I must say I've never seen such a beautiful facility. But that apart, the staff are fantastic, so welcoming. You know, I thought with my accent I'd have trouble, but absolutely not. They're a very engaging group of people, and I enjoy myself every day at work.
Excellent. So give us a little bit of an overview of the size of the facility and the scope of what all happens. Not all, but...
Well, Thunder Bay Regional is, as you know, an academic acute care health science center, one of 24 in Ontario, probably among the 10 largest facilities in Ontario, with on paper 375 beds, 2,800 staff, 300 privileged physicians, 500 volunteers, 85 patient family advisors. So it's a very large organization, the largest employer in the Northwest region, essentially. We have a very significant budget, over $375 million, to provide care to the entire Northwest region. So our mission is tripartite, if you like, clinical in serving the Northwest region for primary, secondary, and tertiary care. So we're the single provider of tertiary care, which means specialists and subspecialty medical care happens here. And we support the 10 small hospitals in the region, providing them all sorts of clinical and back office support, because they're too small to be able to attract and retain the specialists that they need to serve their community. My vision is that we try to export our services, avoid people coming to Thunder Bay Regional. So we have different programs out in the region, such as dialysis satellite units. We do surgeries in orthopedic surgeries, for instance. Now we're expanding in urology. Eventually, maybe other subspecialties will also develop. We're currently recruiting adult and child and adolescent mental health specialists, so we can expand our regional critical care response service. This service or program is led by our intensivists, the doctors that oversee the care of very critically ill patients in the intensive care unit. So we've been very successful at supporting the small hospitals in the region when they face a critically ill patient, avoiding some of those patients coming to Thunder Bay Regional through telemedicine supported service. We'd like now to expand that to mental health, pediatrics, some of the basic medical specialties. So in a nutshell, that's the clinical mission. The academic mission, we teach, train physicians, nurses to the tune of 1,500 students a year. And we do science, research with our research institute, where we have about, I'd say, 40 or 50 staff that operate on the basic science side of the business, but we also have over 100, almost 200 clinicians that do research. So we currently have 150 clinical trials or clinical research projects on the go at Thunder Bay Regional.
We need to take a short break. Please stay with us and we'll find out a little bit more about our local hospital health sciences center. Welcome back to Community Conversations. I'm your host, Steve Mantis, and my guest today is Jean Bartkowiak, who's the CEO and president of the Thunder Bay Regional Health Sciences Center and the Associated Research Institute. So Jean, you were talking about kind of the overview of all these things that are happening at the hospital. There's quite a bit, but there's even more, you were telling me.
Oh yes, well, I forgot to mention the foundation. So we have a very, very active foundation that's in many respects supporting our mission and, supplying us money for our research, for our clinical needs, which helps attract and retain specialists. So thank God we have those hundreds of donors and tens of people volunteering at the foundation, and the 10 or 12 staff that man the operation on a daily basis. And I would be remiss if I didn't also recognize my boards. Actually, we have a foundation, a research institute, and a hospital board that are all very actively supporting our mission. So again, about 12, 13 members on each of these boards that volunteer hours every month to give us their advice and guidance in managing, leading the organization.
So not only do you have to look after 375 beds, 2,800 staff, but you have to go out and beat the bushes for more money.
Not me personally, I do support that, but I have the foundation that does that. Now the 375 bed, that's what's on paper. In reality, we have more beds than that because the demand exceeds sometimes the actual number of beds on our permit, if you like. So I currently operate 64 beds at Hogarth Riverview Manor for transitional care that we provide patients who no longer require acute care. So thanks to the support of my peer hospitals, such as St. Joe's Care Group, we were able to improve flow of patients, discharges outside the acute care hospital where patients receive the level of care that they need.
So, in the news, a lot of talk about overcrowding at the hospital and the issue you've been talking about, that sometimes there's nowhere for people to go once they are getting a bit better but still need further care.
Yeah.
And the funding is part of that challenge. You mentioned, okay, you have a permit for the 375 beds. Mm-hmm. Does that mean you just get paid for the 375 and all the other ones you got to fundraise for, or how does that work?
Funding for hospitals, especially specialty hospitals, is a complex challenge. You have base funding, then you have bundled care, you have agreements that support different pockets. Cancer Care Ontario that funds part of the operation. Core Health for the vascular part of the operation also provides funding. So we have probably 10, 12 different sources of funding. Plus, we also get money from the private sector. So we run a parking lot. I know this is an area where I get a lot of comments.
The main complaint in Thunder Bay.
Yeah,
I got to pay for parking?
Exactly, because this is not an insured service. And honestly, you have other means to get to me. There are taxis, buses, you can walk. I walk to work. Bicycle, there are other ways of getting to me. But the money that you pay goes back to the research and clinical operation. So in a sense, it's kind of supporting the mission of the hospital. So funding a hospital is a very tricky business, essentially. Currently, this is an area where we have discussions with the ministry, the funders, because there is a recognition that we're very efficient administratively and to a certain degree clinically compared to peer similar sized organizations. But the public purse is such that the money is hard to come by. But since I've been the CEO, we have been relatively successful at balancing. 1 year we had a small surplus. to other years, small deficits, but overall, close to balance, essentially.
So the hallway medicine has been in the news a lot. How are we doing there? This has been an issue that's been challenging for us for years.
Yeah.
How are we doing now?
This summer, knock on wood, was better than previous years. We saw lower numbers of inpatients in the beds, probably thanks to many different factors. You know, this is healthcare is a very complex. Actually, researchers deem that the most complex type of organization humans have invented. So it's a complex situation where all sorts of factors generate admissions and discharges. But overall, we've been operating at lower numbers. This morning, I only had 340 inpatients in my bed, so it means I had a little margin to maneuver. So we're seeing improvements, but there's still a ways to go. So we are looking at how to avoid, first of all, admissions. There are better practices, such as, for instance, ambulatory surgery instead of inpatient. So we're monitoring constantly how our surgeons are doing. On that score, I must say that our surgeons are very, very good, and in some respects, we're stellar, not just in Ontario, but in the country. For instance, our orthopedic surgeons have started doing a hip and knee replacement on an ambulatory basis, which is a major surgery, but it's unbelievable.
And you go home at the end of the day.
Yeah, home, but you have to have physiotherapy, exercise, and some treatments at home, but essentially you don't need to stay in the hospital. So avoiding admissions is one bucket where we're trying to invest more energy in making sure that only those who need my level of care come to Thunder Bay. And that involves also my peer small hospitals. If we can avoid transfers, that's better for the patient. They stay in their community, close to their relatives, caregivers. So that's an area. The other area is in managing length of stay. So we've started implementing best practices such as expected length of stay, and now we will be looking at how we will engage patients and their families right from the get-go. You're admitted for a surgery. For that kind of condition, your expected length of stay will be, let's say, 3 days. So you can already start planning your post-discharge care, how you will arrange to have what you need at home. So that's a better practice that we're looking at. And lastly...
We need to take a quick break.
Oh, sorry.
We'll be right back.
I talk too much.
Please stay with us. Welcome back to Community Conversations. I'm your host, Steve Mantis, and my guest today is Jean Bartkowiak, with the CEO and president of the Thunder Bay Regional Health Sciences Center. So, Jean, like, there's so much going on there, and it sounds like you've got a plan that's starting to work, both in terms of helping people not having to come into the hospital and helping them leave more quickly. Where's the bottlenecks now? Or do you think you got it figured out, or what's next? What do you have to tackle next?
Well, those are the three areas of admission avoidance, better bed flow, and then safe transitions back in the community so you don't have to come back my way. So I have teams now of staff that are engaged at looking at what are the best practices out there, not just in Ontario, but worldwide, and how can we implement those strategies, not tackle too many at a time. That's a recipe for disaster, but where are the low-hanging fruits and what will actually work for us? I also have to engage my community, the 10 small hospitals I serve, St. Joseph's Care Group, but more so the family health teams. The primary care is very instrumental in ensuring patients or individuals stay healthy safely in the community. We are facing a challenge with frailty. We're very successful at saving lives, but unfortunately, when you avoid death, you end up with chronic conditions. And we see a growing number of frail adults and elderly in the community that, for all sorts of reasons, don't have the appropriate supports and end up in the emergency. So how do we make it so that we have those safety nets in place in the community to avoid those frail people, their condition aggravating such that their caregivers or themselves decide to come to the emergency room? These are not, emergencies are what it's called, an emergency. You get hit by a car, that's an emergency. But when it's your frailty that warrants coming my way, we need to look at what's not working out there for those patients. And that involves nurse practitioners, family physicians, and other primary care providers in the community. The challenge I face is it's easy enough to go to Nipigon and talk to the staff there, but to go to Thunder Bay where there are many different clinics with hundreds of doctors, family physicians that are not necessarily involved directly with the hospital. How do we engage those primary care providers to support their role in caring for those patients? And I appreciate the challenge for them too, because those individuals are sometimes very complex. They come with many different conditions, so it's not easy for those primary care physicians with limited resources to look after those patients. So how do I make my specialties, the sophisticated equipment, accessible to support those specialists?
So another issue that seems to happen around the emergency is that there's a fair amount of our population who don't have a family doctor.
Mm-hmm.
So they're kind of like, oh my God, what do I do? And we also have a fair number of folks moving into our community on a regular basis as well. And of course, you start off, you don't have a healthcare provider either, a doctor or nurse practitioner.
Yeah.
So I'm guessing that is what makes up a certain proportion of the folks coming to emergency.
Yeah, but I wouldn't say that's the brunt of the challenge we're facing.
Okay.
Those are quick fixes,
Mm-hmm.
usually. We have an assessment tool that tells us the severity of the cases, and we don't get that many cases that are low severity, which tells me that people are getting care elsewhere than relying on the emergency room for nicks and bruises, essentially. What we're seeing are severely frail individuals with many conditions. That's one big challenge. And the other challenge are the acutely ill patients. But we have a good system to triage those patients and make sure that those who need immediate attention get first. And I know that irritates people in the waiting room, seeing people pass them by, but they have to appreciate that this is not a lineup in a bank. You know, you're in a hospital, and we treat very sick people. So we have this system in place that allows us to determine how severe your condition is and how soon you need to see a doctor.
So we have just a little bit of time left. So what do you see coming up over the next year or two of areas that you're going to focus on and try to find that right balance?
Well, apart from what I've explained, we're looking at developing a new program, cardiac surgery. We've been successful in the last couple of years at developing vascular surgery. Now we have specialists in that discipline, thanks to a partnership we have with the University Health Network in Toronto. And the UHN is also supporting us in developing cardiac surgery. But we're a far cry from there. We have to convince the ministry to invest millions of dollars in retrofitting our operating suite and building more critical care beds to support those patients after they've been operated. But if we're successful, that will allow us to avoid approximately 400 to 500 transfers to Toronto per year. So that's that many more patients that will get treatments in Northwest Ontario.
And so if people want to find out more information, what's the best way for them to do that?
About the hospital?
About the hospital, the things we've talked about?
Well, we have a website. The foundation does too, where we explain essentially who we are, what we offer, and what our projects are. We're on the verge of completing our 2020 strategic plan. We will start engaging our internal and external stakeholders in developing a new plan, and the population will hopefully get engaged in telling us what they expect from us.
Thank you so much for coming on the show. We're out of time. Thanks for watching, and please stay safe.